Very good morning to one and all of you in the audience, dear friends. Uh, I thought instead of just going on and on about smile alone, and I'm not sure there are smile users here, so I thought I'll talk a little on smile and also on the different challenges which come with smile, so that it gives you a broader overview. I'm sure there are going to be a time point when you all are going to be doing the procedure, so it's just something which goes to your memory bank and is of use to you all. Not moving. Mouse is not connected. Why suddenly problem? Yeah, you can reset the timer. Can reset the timer? You want me to use this? Huh? So here we go. Essentially, as I'm going to show you the video of how a smile procedure is being done, what I want you all to understand that essentially a small incision or a pocket incision is being created, and we are creating the plane of separation of the lenticule which is to be removed, and the removal of the lenticule is actually shaped to do the refractive correction. So the docking is the most critical part, where the optical device has to be gently brought down and the cornea should be just moist and the conjunctival sac should not be overly filled with fluid, and then you press on it, you ensure it is centered. The centration is the most critical part. The posterior lenticule cut, the side cut, the cap cut, and finally the incision cut is done, and then the suction gets released. You hold on to the inferior pole of the cornea and then create a pocket between the lenticule and the upper surface of the cap, go deeper to the lenticule and create a pocket, and then go along the superior plane and then separate the tissue bridges, which was discussed by the cavitation bubbles which are created. You need to separate them with this blunt spatula right from end to end so that you ensure that it's free, then go in the deeper to deeper plane and then go all the way to the extreme end. There are different ways by which you could separate the lenticule, and you could actually see the lenticule folding on itself, and it just comes freely at one go if done appropriately. I'm going to show you just another simple way of dissection. The way is to not to go back in the deeper plane and separately completely, just separate two half segments, and then so that it's held tightly. A thing needs to be held tightly when you go on to separate. And now you can see that the lenticule is first being separated from the cap, and then you go into the deeper plane and you just go halfway down and then go all the way down, and then you separate the lenticule and you could see it folding on itself. And once the learning curve is crossed, then it's a free lenticule at every time point. There are different ways, again, which you could do it. But again, the other important thing we need to understand, that the understanding of topography, the understanding of cross-linking has taken us a step forward, where we have come to understand that it makes sense to cross-link along with laser vision correction. And if you could do cross-linking for a LASIK flap, you could do it for a PRK flap. We have the ingenuity to incorporate into smile procedures, like supposing you're doing a little higher refractive correction than the cornea would allow, or a suspicious topography. All you need to do is to do the smile procedure in the routine way, the gentle dock, ensuring that it's centered, and then separate the lenticule and take it out, and then use Vibex Extra, which is 0.25% riboflavin, place it in the area for 90 seconds, and then wash off that interface, and then irradiate it with, see, there's a big problem here. And this is the energy which is used, which is half the energy which is used for the regular keratoconus protocol, 2.7 joules per centimeter square. And this is accelerated cross-linking which is being used here, 30 milliwatts per centimeter square, and we expose it for 90 seconds intermittently, like in LASIK flap, where you would keeping the corneal surface prevented from getting dehydrated with riboflavin drops. Here at the most you could use a drop of saline as it goes on. This mouse is not working. It's going to be difficult for Rishi also. What is happening? It's not moving. Now, having said this, the critical steps is that you need to have a gentle dock. Your cornea should not be dry. Your energy setting should be right. The spot separation needs to be adjusted. If 3-4 cases have an OBL which is dense, there are certain areas of dark spots when it gets to be very difficult in doing your tissue separation. And this was a case where a patient had an initial suction loss and a redock was done and the treatment was continued and the OBL was quite dense. So I find that I'm not able to go ahead and separate it, so I try to remove it as you would peel a capsule or excess. But see, I have enlarged the incision site, and that's something very critical. This was in my first 10 or 15th case, but now you would know how to deal with this situation. However it's mandatory that you go and separate the lenticule completely rather than peel it in this fashion. And even in the remote situation where there has been a rip of the incision, believe me, the next day these eyes do as good as any of these eyes with no loss of BCVA. Now this is what I meant as a dense OBL and those dark spots which you see. This is essentially because overlying cornea would have been dry in some areas, or the optical apnanating device, the undersurface could have been moist, or there could be some particles stuck to it. So you need to be sure that the contact glass of the applanation device is absolutely clean and the cornea is just moist, even in the process of positioning the optical device on the eye, and as the dock comes slowly down, because it needs to be a gentle dock, the corneal surface could get dry. So even halfway while you're bringing the optical device down, you feel the cornea gets dry, go back in and just gently moisten the cornea and see that the cul-de-sac gets dry with using a Merocil, and then go on to do your procedure, because separating this lenticule could be a challenge in your early days. So it becomes very mandatory, especially in these small parts when the lenticule becomes quite thick, that you go identify the exact plane of separation and go in above and below. When you go under the lenticule, you actually feel a resistance, and that's a giveaway to tell you that you are on the right plane of separation. Go right completely end to end, and then sometimes the lenticule would still not come as a free lenticule, and as you're separating the lenticule, you could see that the great resistance which was there. Sometimes the lenticule might come piecemeal in these situations, so you need to spread out the lenticule on the cornea to know whether you have actually separated it completely. Now this is another challenging moment which could happen. It was a refractive error of 1.25, and I think I've created a pocket, but each time I've gone in the undersurface of the cornea and the lenticule has got stuck to the cap, and I'm going about trying to dig in all directions and I know it's stuck there. Then you need to use that blunt end of the spatula and try to separate it from the cap, go gently, and at this point of time keep an eye that you are not ripping the incision, that you do not overly stretch it and then comes free. But there are different ways you need to adopt. I could have shown you 20 videos of how the lenticule was stuck to the cap and the different challenges which come, because each time you need to use a different way of approaching it. And so sorry. Now, this was another situation where even this is not working appropriately. No, the previous one. Go to the previous one. Yeah, we'll click it. Yeah, so now if you look carefully, I have managed to separate the lenticule from the underlying the cap, but when I'm going deeper down, I'm actually in the same plane. And these are challenges which occur essentially with a thin lenticule more so, because it could be just about 20-25 micron thick and you may not have identified the plane, but there are ways of understanding and going about it. So I keep all the time, I'm just separating the lenticule from the overlying cap, and I think I've gone deeper to the surface, but again, it's been the same. So then at that point of time, you just need to lift up at the edge of the incision to identify whether it's stuck to the overlying. I'm trying to search whether it's stuck to the undersurface of the cap, but if it were stuck, you would actually see a fold of the lenticule. I'm not able to identify that. And as you can see, I realize that line, that gray line where it's stuck to the bed. So then I need to go deep down. There would be some kind of a resistance which I would feel when I'm trying to create a pocket, because by now the lenticule is completely stuck to the stromal bed. And now once I have identified it, I need to go in with a spatula, and there would be a little more resistance I would feel than I would normally feel, but then it tells you that yes, you are bang on, you have at last achieved the space, and you can already see the lenticule, that fold of lenticule. So you go back and ensure it's completely separated from the edges of the cap, and then you are able to remove the lenticule. Can you go on to the next? And of course, you need to spread it out. Now this is a situation where inadvertently a hair follicle has come to overlie the cap, and you can see that that bit of the femtodissection has not occurred. It's an extremely rare, bizarre situation. It just tells us that we need to be conscious that normally there's no pooling of fluid in the conjunctival sac, but the eyelashes are kept totally away. I knew it's going to be a daunting experience, so I tried to go on both sides and separate it. And you need to be very careful. These caps could suddenly be thin, and there could be a buttonholing of the flap, and that could trigger off an epithelial ingrowth, a vicious cycle. But I actually finally do manage to separate it, as you can see, and then go on to the next slide, that I'm finally able to separate the lenticule and take it out. Next slide. Now this was a patient wherein there was a suction loss at the side cut. So then you can continue. That smile allows you to continue from there on. So, but you have to redock and to see that the undersurface of the applanation device is not moistened with any fluid. But one challenge is there has been a raster pattern which has been nearly double in some of these areas. So the separation of the lenticule, because the OBL is going to be dense, and also you're never too sure because the optical device which has been cleaned, it definitely is not as it was when it was virgin and the first time it was being used. And then you can see the resistance which I feel when I'm trying to separate it from the undersurface, but I see the lenticule folded up, so I pull it out. But there is this doubt whether did I remove the lenticule in toto, and I realize that 3/4 of it has been open, and that there is, and when I look carefully, I notice that small portion which is there. I take it out. You could even place it, position it properly to know whether in fact the right size has been removed. And once I'm reassured, then I carry on. So it's in early days, it's very, very important that you do a complete separation. Next slide. Now this was a case wherein this patient had a very routine smile procedure and had a tiny small refractive error, but was completely disturbed with the vision, and came back to me after 6 weeks with this kind of an appearance of a small epithelial ingrowth. It was a routine procedure. There was no obvious injury of the cap, a very easy lenticle separation, and the incision size was also had not enlarged, which didn't show that I had not dug up the incision size. Go to the next slide. And then we all know it is the areas is how you implant the epithelial cells into the nest. So while dissection, have you kept going in and out with your blunt spatula? Next slide. So then our management technique depends on whether it is encroaching the visual axis or there is any progression of stromal melt. Next. And if it is encroaching the visual, here, it did come to the visual axis, but there was no track to the surface. It was just an isolated collection of cells. And if it had not visually disturbed the patient, we need not have gone further. So however, it was quite disturbing the patient, so there was the only way to go about it as, it was totally stuck. So as you can see, I could even not identify the incision, but finally I did manage to identify, but I knew that I cannot be placing a mitomycin sponge because there was a very small gap here. So I just somehow managed to create a small pocket and go in with the blunt end of the spatula and reach that area where the epithelial cell nests were collected. And they debride on the undersurface of the cap and on the stromal bed, and then wash it with mitomycin C of the same concentration for 30 seconds, and then come out. And there was this minimal haze the next day, but the patient ended up with a planar refraction and was very happy. The last of the situations which I'm going to show you is about the DLK. We all know that epithelial defect actually increases the possibility of a DLK, and there was only one study which was quoted about DLK at that point of time. But we all know that the femtosecond laser, there's increased photodisruption, there is greater inflammatory response, greater release of inflammatory cytokines. But one advantage with SMILE is that the pulse inner frequency is 500 Hertz, but the pulse settings are low as 130 to 150 nanojoules. And we also know there's less stromal exposure, there's less keratocyte apoptosis. So then, but there was the one case which was reported about DLK was a thin lenticule, and these thin lenticules, and you tend to use a larger lenticule diameter so that it's easier to remove these lenticules. There are situations when there could be a greater inflammatory response. We had just this one case series in our DLK. This patient came back the next morning with this large epithelial defect and lot of inflammatory cells in the interface. So it seemed to mandate that we need go and do an interface wash, and of course club it with topical steroid drops and lubricants. The interface wash was done in just a routine fashion, as we would lift a flap and wash, and this is how I did it. And the epithelium also healed in a day, and the cornea interface cleared up. And again, the last is the enhancements. Just one sentence about how there are different ways by which you could do enhancements, and the enhancements in SMILE are far below what has been reported in LASIK. You could do a surface ablation to correct the residual refractive error, or you could use a circle software. You could do LASIK on the flap. You could do a repeat SMILE. This was a case, there's just one case where we had to enhance. I did a surface ablation, and there was one case where a circle software was used. Essentially, the cap is converted to a hinge. You can see that we are it's extended 1 millimeter on circumferentially, and then you do the procedure as you would do routinely. Once the side cut is increased, you just go in with the blunt spatula, identify the edge, lift the flap, and as you can see, this is how it's being done. You just lift the flap, go into the interface, and then separate it all around, go and do the residual refractive correction, and you get out of it. So essentially, I know it has been a very disturbed talk of mine with my not knowing how to handle the mouse, but all I would like us to understand is there are all of what complications I showed are something very much early in the learning curve, and SMILE actually is a consistent performer. The only message you actually need to understand is it's a corneal based section, so it has to be a gentle dock, so we need to take care in dissection, and you need to see it's a centered dock, and all of these patients do very well.